Good evening to all the aspirants present here. We'll be starting with the session 2 of Neurology, which will be taken by Dr. Varun Pushkarna, sir. So you may take over. Thank you.
Yeah, thank you. Good evening, doctors. I must appreciate your effort to go in for EDIC preparation. So in EDIC, it is usually focused on decision making and going as per the present protocols worldwide, specifically as far as Europe is concerned. My style of teaching is a little different. I take up the questions, then I give you the heading under which the question is asked, although those kind of headings will not be declared in the examination. But just to keep your thought process going on in the right line of direction, I prefer letting you know that the question is based on which disease or which condition or what kind of decision making I'm expecting out of these questions. I would like you to participate in this class so that the more involvement means better outcomes as far as the class result is concerned. Baki, when you appear in the exam, you will have different level of confidence when you are prepared with discussions. The questions are everywhere, but the discussions, they are the most important part of the classes. So you can unmute your mic whenever you have to say. Otherwise, keep the mic unmuted, and we'll have a good discussion. Don't worry. We'll begin with this question on Guillain-Barré syndrome and its management. A 42-year-old man presents to the emergency department with progressive weakness in his legs for past 3 days. He had a diarrheal illness a week ago. Neurological examination shows areflexia and bilateral lower limb weakness. He is now developing shallow breathing. ABG shows a pH of 7.45, PaCO2 of 29 millimeters of mercury, PaO2 of 85 millimeters of mercury on room air. Now, which of the following is the most important next step in management? Number 1, start high-dose methylprednisolone. Number 2, obtain a contrast MRI spine. Number 3, begin IV immunoglobulin. Number 4, intubate and initiate mechanical ventilation. Number 5, start plasmapheresis and corticosteroids. So these are the options that are given to you. This is basically to check your wisdom on managing this patient. Although it has already been declared that this patient is a Guillain-Barré syndrome patient, but in the exam you will not get a hint like this. So you'll have to pick it up from the question where you can see that it is a progressive weakness in the legs for past 3 days, which started after a diarrheal illness. Presence of areflexia and bilateral lower limb weakness, which is ascending type and now involving respiratory parts, allowing shallow breathing, and the ABG showing a little hyperventilation, showing a CO2 of 29. So how the management will change?
I would intubate and initiate the mechanical ventilation given the time for IV immunoglobulin might take some time.
Okay. Anything else? What about
shallow breathing? Shallow breathing, intubate and ventilate.
So right now we have one answer that we have to start the intubation and initiate the ventilation. So if I have to just go through, I've already told you that this is a Guillain-Barré patient and we've discussed the diagnostic criteria. So in a patient of Guillain-Barré syndrome, just having a low CO2 levels, they are an indicator that the patient's respiratory muscles, they have started to feel the heat of situation. So right now they are blowing off carbon dioxide. Eventually they will retain it and then they will crash. So the first priority in the patient of Guillain-Barré syndrome is to assess whether they need intubation or not. So we always use a 20-30-40 rule. Anybody who has the idea of 20-30-40 rule? No? So we follow the 20-30-40 rule. So what is 20? 20 is the forced vital capacity less than 20 ml per kg. These are the criteria, threshold indicators for intubation. Okay. Negative inspiratory force of minus 30. Now these are the figures that you need to remember. Negative inspiratory force of less than minus 30 centimeters of water. It is calculated in water. And a total vital capacity of less than 15 ml per kg, and SpO2 target of less than 92%. Rapid progression, very important criteria. Rapid progression, that is, if somebody has deteriorated within 40 hours. So that is how you can remember that what you all have to see when the patient needs an intubation. So this rule, if you keep following, you can just answer these questions. So the patient who is showing respiratory muscle involvement is having tachypnea, low pH CO2, shallow breathing. This means this patient is soon going to have respiratory paralysis along with. So in GBS, early elective intubation, it is preferred. Why? Because if the patient crashes, and in that case, nothing else will help. If you can calculate, sorry, I forgot to mention the 40 here. Yeah. So that is peak expiratory flow of less than 40 liters per minute. So if that is there, then you have to intubate pretty early. IVIG, plasmapheresis, they always need time. They need time to start showing their effect. So eventually you will need them, but airway protection will always take up the precedence. Steroids, they are not beneficial alone in GBS. MRI spine is not going to help in this patient. Now, if I have to ask you, what would be the sequence of management in this patient? Can you tell me?
Yeah, first is the airway management, and then the initiation of immunoglobulin.
Okay. So how do you place immunoglobulins versus plasmapheresis?
We would give 5 doses first, and if it is not beneficial, then we can go ahead with plasmapheresis.
Okay. So let me tell you that there have been head-to-head trials of plasmapheresis versus IVIG therapy in case of Guillain-Barré syndrome. So the trials say that if you use IVIG, the chances of recovery are close to 30 to 35%. Similar is the percentage of plasmapheresis. And the data also goes on to say that if you combine both, that means IVIG and plasmapheresis combined, the outcome is close to 55% or maximum 60%. So some people, they utilize both of them together. uh, it is either or, it is not one after the other. It is very important. Either you do IVIG or you do plasmapheresis. Both are equally effective. You can combine them, but it is not in a sequence that you do IVIG first and then you give plasmapheresis. People who are doing it, they are doing it just out of habit. Otherwise, the dose of IVIG in respiratory paralysis situation of Guillain-Barré is 0.4 grams It is 0.4 gram per kg per day for 5 days, or plasmapheresis. Is that clear? So you don't do that in a sequence, you just do that either or you can combine, because now the data is coming. So it is very important that the sequence of events should be: first, assess for any respiratory deficit. Second, if you find respiratory deficit, intubate this patient, because having a live patient paralyzed is a better situation than a paralyzed and a probably a dead patient eventually. So it is always in the best interest of the patient to intubate when you start seeing the carbon dioxide coming down. So functional forced vital capacity of less than 20, negative inspiratory force of less than 30, and peak expiratory flow rate of less than 40 liter per minute is the 20, 30, 40 goal for. If any of these criteria is met, see, it is beautiful. You don't need to have all of them. Any of these, 10, this 20, 30, 40, any of these criteria, if they are met, the end result is intubate immediately. Okay? All right. So let's move to the next situation. Myasthenic crisis, a pretty common situation in day-to-day critical care and in EDIC exam also. So, a 63-year-old woman with myasthenia gravis presents with increasing difficulty in swallowing, ptosis, and shortness of breath over last 24 hours. She had recently had a respiratory tract infection. She is alert. Blood pressure is 130 by 75. Respiratory rate is 28. Saturation is 90% on room air. What is the most appropriate immediate intervention? A. Administer oral pyridostigmine. B. Give intravenous corticosteroids. C. Intubate and admit to ICU. D. Start broad spectrum antibiotics. E. Perform tensilon test. From what you can see, the correct answer is C. Intubate and admit to ICU. But I want to know why it is the correct answer and why every other answer is incorrect. So if you want, I can take the screen back. 63-year-old woman who is a known case of myasthenia gravis. She's come with increasing difficulty in, basically, you see that she is having neuromuscular weakness now, and she is having shortness of breath. Now in critical care, we are scared to hell if somebody has shortness of breath, because that is something where you can lose or save a patient. Everything else can take time, swallowing, ptosis, everything. But if the patient has worsening shortness of breath, you need to know how rapidly it is progressing. Now, this patient has became, complaining within 24 hours. So that means this patient is already sick. She had a respiratory infection due to which she has had a worsening of myasthenia gravis. So the immediate intervention right now would be to intubate this patient. But I want to know from you, what are the red flags in the question that demand the situation to be handled with intubation?
Increasing respiratory distress.
Okay, 28 is considered as a moderate to severe respiratory distress, correct? So
And
what
then,
does it tell us? It tells us increased work of breathing. Okay, what next?
and then the SpO2 is dropping down to 90% on room air.
Very good. So the gas exchange is also falling. What else? She has difficulty in swallowing. So that is bulbar weakness. So that means she can aspirate any moment. We need to take care of the airway. Okay. So the three features which are red flags here is: number one, involvement of the bulbar tract muscles, shortness of breath leading to tachypnea and desaturation. leading to tachypnea and desaturation. Although she is alert, so you will need to sedate her down and intubate her. She is only a few hours away from respiratory arrest. If you keep sitting on it, she definitely will crash. So the most appropriate immediate step is to protect the airway and start the ventilation before she undergoes into fatigue. This is myasthenic crisis with respiratory compromise. We should not delay any intubation. So, again, why administering oral pyridostigmine is not the right answer? Yes, oral pyridostigmine is treatment. We give it routinely. But why it is not the treatment here in this case?
It
So
takes
the patient is a known case of myasthenia, so patient would already be on pyridostigmine. But the problem is pyridostigmine is not indicated in acute situations. So whenever there is an acute worsening of myasthenia gravis, you do not give. It is not recommended. It is not at all recommended. Plus, this patient has bulbar weakness. She is bound to get aspiration risk. And gastric emptying is also slowed in these cases. So much so that oral pyridostigmine will increase the bronchial secretions also. So this patient can drown in her own secretions. So first priority is airway. The second priority is again like in Guillain-Barré, either IVIG or plasmapheresis. Okay. Oral pyridostigmine is not recommended in acute myasthenic crisis. Giving IV corticosteroids is absolutely incorrect and it is actually dangerous. Why? Because high dose steroids can actually worsen the myasthenic weakness initially, which is known as what is it known as? What is it known as? It's known as a steroid dip. So it's known as steroid dip. So steroid dip happens in up to 50% of patients. So almost half of the patients, the moment you give them high dose IV corticosteroids, the patient will actually worsen. So steroids are useful in the long-term outpatient management of these patients, but they are never the first step in a crisis. So how you should move? You should intubate the patient first, and in case you want to give, only then give, although it is not recommended in acute myasthenic crisis. Later on in outpatient setting you can use. Third is the correct D, starting broad spectrum antibiotics. What about this answer? So definitely you might prefer giving into antibiotics.
no indication presently because majority of the antibiotics might play on the neuromuscular joints. And
Okay. Yeah. So it is basically the infection has definitely triggered the crisis, but it is an autoimmune disease. It is an autoimmune complication of the infection which has led to it. So right now we need to address the airway, treat the autoimmune part. Antibiotics can go side by side if there is a evidence that the infection is still prevailing. Okay. What about performing tensilon test? What is a tensilon test? Any idea? So tensilon test is basically a diagnostic test. It is not a therapeutic test. It is a diagnostic test where we give adrophonium. Now the problem is the moment you give adrophonium, what can it cause? It can push the patient to cholinergic crisis. It can cause bradycardia. It can cause arrhythmia. It can cause bronchospasm. And adrophonium itself has known to cause respiratory collapse. So This test is always contraindicated in unstable and hypoxic patient. Tensilon test is never done in myasthenic patients. So the only correct answer is intubating and putting the patient to ICU. Have you understood the question and all the options?
Yes.
Good. So what will be the sequence? Sequence will remain similar like in case of Guillain-Barré syndrome. Okay. So you will first intubate, treat the disease later. Be it myasthenia gravis, be it Guillain-Barré syndrome, it will always be airway first, respiration, and then treating the cause. All right. Next question. A 28-year-old man presenting with diplopia, dry mouth, progressive descending weakness. He reports eating some home canned vegetables 48 hours ago. He is alert, his pupils are fixed and dilated, and his deep tendon reflexes are reduced. There is no sensory loss. Which of the following findings is most characteristic of this condition? Number one, normal pupils with upgoing plantars. Number two, preserved reflexes with patchy sensory loss. Number three, ascending flaccid paralysis with preserved cranial nerves. Number four, symmetrical descending flaccid paralysis with autonomic dysfunction. Or number E, acute spastic quadriparesis with preserved consciousness. So the
Acute
diagnosis is botulism.
consciousness.
Yes. So patient has
E.
acute spastic quadriparesis with preserved consciousness. So the pupils are never normal. Okay, this is a textbook foodborne botulism condition. So there is diplopia, there is dry mouth because of autonomic involvement, there is progressive descending paralysis, there is fixed dilated pupils due to parasympathetic plexus in paralysis, there are diminished reflexes, there is characteristically no sensory loss. So if you see there, the correct answer would be symmetrical descending flaccid paralysis with autonomic dysfunction. Okay? So D is the correct answer. That is symmetrical descending flaccid paralysis with autonomic dysfunction. Now, we all know Clostridium botulism, Clostridium botulinum toxin, Clostridium botulinum toxin, it basically blocks the acetylcholine's release into the neuromuscular junction and autonomic synapses. So neuromuscular junction and these are autonomic synapses. So what happens is it leads to cranial nerve palsies first. So number one happens is ऊपर से नीचे आएगा तो cranial nerve palsies will happen first. That is diplopia, dysarthria, and dysphagia. So these three things will happen, followed by descending symmetrical flaccid paralysis. Okay, because it is neuromuscular junction paralysis. Plus, along with that, there will be prominent autonomic dysfunction. Autonomic dysfunction. That means patient will have dryness of mouth, constipation, blurred vision, pupillary dysfunction, and hypotension may also be there. So this is a classical textbook case of botulism. Okay. So unlike Guillain-Barré, it is descending paralysis and there is dysautonomia, which is much more than Guillain-Barré syndrome. Is that clear? So what about the other answers? Normal pupils with upgoing plantars. Now, normal pupils with upgoing plantars, they suggest an upper motor neuron lesion. That is a corticospinal tract lesion, like stroke, like cord lesion. Botulism is characteristically lower motor neuron plus neuromuscular junction problem. So, botulism is lower motor neuron plus neuromuscular junction issue. So lower motor neuron means autonomic paralysis. No, neuromuscular junction means flaccid weakness. So preserved reflexes with patchy sensory loss. Second option. This pattern is classically pattern of peripheral neuropathy. This is peripheral neuropathy, could be diabetic, could be any. So reflexes will be preserved, but there will be sensory loss, which is patchy. Now, ascending flaccid paralysis with preserved cranial nerves is seen usually in Guillain-Barré syndrome. Yeah, some degree of dysautonomia is there, but mainly the cranial nerves are preserved. They may be involved, but not characteristically involved. Okay. Botulism is descending paralysis, whereas Guillain-Barré is ascending paralysis. Then the answer that you gave, acute spastic quadriplegia with preserved consciousness. This is classically tetanus. This is tetanus or cervical cord transaction or brainstem related quadriparesis spastic. It is UMN lesion like cerebral hypoxia leading to spastic quadriparesis in hypoxic brain injury of small children. Okay. So we just did three different kind of setups. One was ascending paralysis. One was a paralysis induced by a respiratory illness in a pre-existing neuromuscular junction disorder. Third is botulism, which is a reversal of Guillain-Barré, which is ascending, but this is descending, and there is heavy degree of dysautonomy or autonomic dysfunction in botulism. Is that clear? Yes? Any questions till now? Okay, so we will move to the next question. A 68-year-old man in ICU for last 3 weeks admitted with sepsis, mechanical ventilation and multiple organ failure now is better but is failing to wean off from ventilator. Neurological examination shows diffuse weakness, especially proximal muscle, that is proximally. There is decreased deep tendon reflexes and intact sensation. Nerve conduction study shows low amplitude CMAPs with preserved snaps, SNAPs. What is the most likely diagnosis? Number one, Guillain-Barré. Number two, myasthenia crisis. Number three, botulism. Number four, critical illness polyneuropathy. Number five, conversion disorder. What is the answer and why it is the answer? Why others are not the answer? Let me know.
This is a common scenario with the patient admitted in ICU for last 3 weeks with sepsis. He's
Correct.
on mechanical ventilated. That means he's on sedation, muscle relaxants, and possibly anti-inflammatory as well. With organ failure, now fails to wean off for the ventilator. Is already ventilator dependent presently. Neurological examination shows diffuse weakness proximally and decreased deep tendon reflexes and intact sensation.
Yeah. So what is CMAP and what is SNAP? So the CMAPs are motor nerve amplitudes. and SNAPs are sensory nerve amplitudes. In critical illness, polyneuro or myopathy, classically you will see low motor nerve amplitudes and preserved sensory amplitudes. This is one of the differentiating factors, NCS. That is why it is given. Always remember, in an examination like EDIC, they don't want to give any extra lines in the question. If they have mentioned any line, that means it has a meaning. That means it has got not only a meaning, but it has got a suggestion towards the answer. No wonder the correct answer is critical illness polyneuropathy, but you need to know what is NCS showing as amplitudes in CMAP and SNAP. So in CMAP it is motor amplitudes, in SNAP it is sensory amplitudes. Why it is not Guillain-Barré syndrome? Because Guillain-Barré syndromes are not already in ICU. They will always come with weakness and get intubated. Uh, the NCS in Guillain-Barré syndrome commonly shows abnormal snaps and abnormal CMAPs, both of them. So, because there is demyelination and demyelination slows the conduction, so all the amplitudes are decreased. All right. In myasthenia crisis, again, in myasthenia crisis, the patient will come with muscular paralysis, and because it's a muscular disorder, CMAP will be normal, SNAP will be also normal. As far as botulinum is concerned, there will be autonomic symptoms and descending paralysis, and the NCS in botulism shows increment with rapid repetitive stimulation, not preserved snaps with low CMAPs. So if you give repetitive stimulation, there will be increment in the acetylcholine. So there are chances that in botulism it will get better. In myasthenia gravis, it will get worse. So this is the situation, and we do not call anything as conversion disorder. Why? Because in conversion disorder, the reflexes are usually normal. Here, the reflexes are decreased. And NCS is normal. Here, the NCS is abnormal. And ventilator weaning failure, ICU course in a conversion disorder, I don't think it is a correlatable thing. Organic cause is obvious. So important is that you remember that in critical illness, neuropolyneuropathy or myopathy, the NCS, it shows low CMAPs, that is motor, and normal snaps, that is sensory. Okay. So critical illness, polyneuropathy or myopathy typically occurs in patients with sepsis, multi-organ dysfunction due to the usual reasons like the ones you described. Weaning off failure, diffuse weakness, preserved sensation are characteristic. EDIC wants to elevate your level by not just saying that this is a classical setting, but proving that this is critical illness neuropathy. How you can prove it? The only way to prove that is with NCS. In NCS, if there are low CMAPs, preserved SNAPs, this points to a axonal neuropathy. Okay? Is that clear? This is the carry home message for this question. Is that clear? Lambert-Eaton syndrome or LEMS. So in Lambert-Eaton syndrome, this question is there. A 55-year-old man complaining of progressive lower limb weakness and dry mouth. He has difficulty rising from a chair but feels stronger with repeated movements. Reflexes are initially absent but improve after exercise. He is a chain smoker. Chest X-ray shows a right hilar mass. Which of the following best differentiates LEMS from myasthenia gravis? Number one, ptosis is more prominent in LEMS. Number two, symptoms worsen with repeated exertion in LEMS. Number three, hyporeflexia with post-exercise facilitation happens in LEMS. Number four, LEMS presents with diplopia as the initial sign. Number 5, presence of thymoma on imaging. So the correct answer is C, that is hyporeflexia, but will get better after exercise. So hyporeflexia with post-exercise facilitation of LEMS. Now, in LEMS, what is the problem is that there are voltage-gated calcium channels. VGCC we call them. So these are at presynaptic terminals. Now, they are responsible for decreased acetylcholine release. So what happens is that when you tell the patient to do more exercise, more VGCC channels they open, because earlier there were antibodies to them, but once you overwhelm the situation with exercise, the channels will open and acetylcholine will release, and the strength will improve with repetition. Reflexes are reduced and absent, but they get better with the exercise. This pattern is not seen in any other disease like myasthenia gravis. So these are actually considered in the neuromuscular emergencies in the ICUs. So you can have Guillain-Barré syndrome, myasthenic crisis, botulism, SIP, and CIM. If you want, I can walk you through each disease, which we have already done, and they will help you, remembering them, because earlier, rest of all the diseases we have covered in the last class. So Guillain-Barré, it is an acute immune mediated polyradiculopathy. So multiple nerves are involved at the radicular level, that is at the level of initiation of the signals at spinal cord, often triggered by infections either respiratory or gastrointestinal. There is classical features are symmetrical ascending paralysis starting from the legs progressing upwards. There is areflexia. They may involve cranial nerves because it starts below, goes upwards. Respiratory muscle weakness is what you should always be looking for. 20, 30, 40 rule is important. Risk of respiratory failure, aspiration are important. There is dysautonomia, BP instability, arrhythmias, urinary retention can occur, but in the lower infradiaphragmatic area. Diagnosis is through clinical suspicion. You can do a lumbar puncture to prove albuminocytological dissociation, that is, the proteins will be increased, but there will be normal cell count in the CSF. Nerve conduction studies can be done. They will show abnormal demyelination pattern in both motor and sensory nerves. ABG is done to assess the respiratory compromise, and bedside, if FVC can be done, they are very important to assess the need for intubation. So the parameters are the vital capacity less than 15, negative inspiratory force of less than minus 30 centimeters. The figures are very important for you. Okay. And peak expiratory flow rate of less than 40 liters per minute. Now, these are very important. Treatment are IVIG or plasmapheresis. Steroids are not effective. So this is about Guillain-Barré. As far as myasthenia gravis is concerned, it is crisis situation. It is acute exacerbation of pre-existing myasthenia. You cannot diagnose. Sometimes patients are diagnosed on first admission, but usually they are already diagnosed, leading to respiratory failure, often triggered by some infection, some medications, or stress even. Clinical features are predominant bulbar symptoms, dysphagia, dysarthria, and then ptosis, diplopia. Only the motor components are involved. Proximal limb weakness is there, respiratory distress is there, preserved sensation. There is only motor involvement. Wherever muscles are involved, only there. Cognition is okay, sensation is preserved. Patient usually has a clinical history. There will be antibodies to anticholine receptor or MuSK antibodies. Hydrophonium test or electromyography is used to diagnose it. Never ever do tensilon hydrophonium test in an acutely ill patient. Why? Because it can cause bradycardia, increase in the secretion, and the patient can pool in their own secretions and die. Perform ABG and bedside spirometry to confirm the respiratory status and need for intubation. Elective intubation should be done before fatigue or hypercapnia sets in. Like 20, 30, 40 rule, we don't have such rule in myasthenia management. And you should stop the cholinesterase inhibitors if patient is intubated to reduce the secretions. Start IVIG or perform plasmapheresis. Steroids should be used with caution because they can actually cause a steroid dip, which is actually a transient worsening. And once you have intubated, you can take all the chances, but not before intubating and treating the underlying cause. Coming to botulism, botulism is a rare neuroparalytic illness, neuroparalysis, caused by botulinum toxin, which actually binds to presynaptic acetylcholine receptors and inhibits the release at neuromuscular junction. Causes are the Clostridium botulism is the bacteria which is causing this through its own exotoxin, botulinum toxin, which hence it is found in home canned food or honey or contaminated wounds. Classically, features are of symmetric descending paralysis with cranial nerves being involved very, very early. It is the descending paralysis, so it starts from above downwards. Limb weakness will follow after the upper respiratory tract involvement. So they are actually intubated much earlier than Guillain-Barré patient because it starts from above downwards. Pupils are fixed and dilated. There is photophobia. There is autonomic symptoms like dry mouth, hypotension, arrhythmia, and constipation with urine output not coming because of the urinary control loss. Then the sensation and cognition are preserved as in myasthenia gravis. Diagnosis is purely clinical, confirmed by toxin assay, and there are low motor component and there is post-tetanic facilitation. That means the more you stimulate, the easier it is get to elicit the reflexes. Treatment is ventilation in respiratory failure. Equine antitoxin only given very early can improve outcome and monitoring for complications. Critical illness, polyneuropathy or myopathy. Now, this definition is acquired neuromuscular dysfunction in critically ill patients. How you diagnose it? It is either cause sensory motor axonal polyneuropathy or primary myopathy with myosin loss. They are always overlapping clinically. Risk factors are septicemia, hyperglycemia, prolonged mechanical ventilation, and high dose steroids and neuromuscular blockers. Clinical features are flaccid paralysis, failure to wean off, preserved consciousness, hyporeflexia. Diagnostic test is nerve conduction studies. In CIP, that is this critical illness, polyneuropathy, low CMAPs and SNAPs. In myopathy, it is low CMAPs, normal SNAPs, and abnormal EMG because it is the muscular weakness. And muscle biopsy is needed to prove the myosin loss. So management is keep repeating weaning off, physiotherapy, DVT prophylaxis, good sugar control, avoiding neuromuscular blockers whenever possible. As far as the LEMS is concerned, it is an autoimmune disorder usually seen in lung cancer patients. It is just like myasthenia gravis, but there will be improvement in the reflexes after repeated activity. There will be a suggestion of neoplasm, preferably lung cancer in these cases. There will be voltage gated calcium channel antibody testing to be done. How do you treat them? Treat the underlying cancer, use immunotherapy like steroids as a thioprine. There is a trial drug, emifempridine, which enhances the acetylcholine release. Because it is an antibody mediated problem, always you can use plasma pheresis. Now, coming to other important things, coma scales. So there are GCS versus 4-score scale. A 62-year-old man is found unresponsive after a witnessed cardiac arrest. He is intubated and brought to the ICU. On examination, there is no opening, no eye opening, no verbal response, no localization of pain. So this 62-year-old man who was found unresponsive after a witnessed cardiac arrest is intubated and brought to ICU. Now no eye opening, no verbal response, and he localizes to pain. Pupils are equal and reactive. Corneal reflex and cough reflex, they are present, they are intact. EEG is unremarkable. Now, which of the following best describes this patient's neurological status using the 4 score? Number one, 0. Number two, 2. Number three, 4. Number D, 6. And number E, 10. So, what is the 4 score of this patient? Any idea? So 4 score, basically the answer here is 6. Now this 4 score is basically including 4 domains, and the score here will be eye response is 0, and motor response is M, which is I will tell you how it is 3. So they are 0 to 4. Like we do in GCS, it is 1 to whatever. So GCS can never be 0, wherever 4 score can be 0. So 4 score is anywhere between 0 to 4 for each. So there is EMBR. So E is eye response, M is motor response, B is brainstem reflexes. Very important, not considered in GCS. Brainstem reflexes. And R is respiration. So all are rated from 0 to 4. Now, so this patient has no eye opening. So that means it is 0. The patient has motor score of 3. He is localizing to pain. Now, motor score M 0, 1, 2, 3, and 4. Now, 0 is no response. 1 is posturing, like tonic posturing. Second is flexion, withdrawal. 3 is localizing pain. This is much easier way actually. And 4 is thumbs up. The patient, even unconscious, can give you a thumbs up sign or OK sign as it is called. So this is the motor scoring of 0 to 4. So here he's localizing pain, hence it is motor reflexes 3. Now coming to B, that is brainstem reflexes. So brainstem reflexes is again 0 to 4. Brainstem reflexes. So in 0, there is absent pupil, corneal, or cough reflex. This is, I like it very much, this scoring system. I tell to my residents always that GCS is a scoring system for mainly for neurologists. For us as intensivists, it is the 4 score. So number 1 is pupils are fixed. Number 2, pupils or corneal. So remaining to the eye only. Corneal absent. Number 3 is one pupil wide or one eye reflex, corneal reflex absent. Means one eye is involved. 4 is present pupillary and corneal reflexes. So here it is mentioned in the question that the patient has both pupils are equal and reactive. Corneal reflex and cough reflex are intact. So this patient is B4. Okay? B4. All are present. And R is respiration. So R is respiration. That means 0 is apnea. That is either 0 is either apnea or ventilator dependent. So this is a very good scoring system. If you are using it in your ICU, you will be much benefited with this. And in EDIC, you might get an exam question from this. So this is respiration. So 0 is apnea or no ventilation, apnea or patient on ventilator. 1 is breathes above ventilator setting, means you have set frequency at 18, patient breathing at 20. Number 2, the respiration, patient is not intubated but having irregular breathing. Irregular breathing. Number 3 is patient is not intubated and is having gasping breathing. That is Chinese-Stokes breathing. And number 4 is patient is not intubated and patient is breathing aram se, regular breathing. So not intubated and fine. Higher the score, better is the patient. So now we are told that he is intubated and the patient is likely on ventilator. So we have this patient as 0 plus 3 plus 4 plus 0, so 7. So D6 is the closest as far as. So I preferably feel that unlike GCS, a patient who is intubated, 4 score is much more useful in these patients and is very good. Next question is metabolic and structural coma differentiation. Very important alternation question. So a 46-year-old woman with a history of chronic alcohol use presents with progressive drowsiness. On examination, GCS is 9, pupils are equal and reactive, horizontal gaze paralysis is there, there are no lateralizing signs, head CT is normal, laboratories show sodium of 130, glucose of 5.2 millimole per liter, ammonia of 110 micromole per liter. What is the most common cause? Here, what is the most likely cause for her altered mental status? Brainstem infarction, hepatic encephalopathy, Wernicke's encephalopathy, hyponatremia, or hypoglycemia. What is the answer?
B.
Why?
This patient has got horizontal gaze paralysis
Very good.
and history of chronic alcohol.
So this patient has hepatic encephalopathy. Now we are getting to this answer because there are no lateralizing signs. There are preserved pupillary reflexes, very high ammonia, which is characteristic of hepatic encephalopathy. Structural lesions, if at all, they would be present, like brainstem infarction, they would show some brainstem signs, focal signs, abnormal pupils. Hyponatremia is mild, so it is unlikely to be a sole cause, can be contributory, but not a sole cause. So, in the only confusing answer here could be Wernicke's encephalopathy. Why it is not Wernicke's encephalopathy?
Ammonia?
Correct. So, given the history that this patient has ammonia which is elevated, so the official answer would be hepatic encephalopathy because of the history being given. Chronic alcohol user, again, Wernicke's encephalopathy can be present in chronic alcohol user. So, ammonia normal is less than 35. It is much more than double or triple probably. And drowsy, GCS is low. But let us see about the horizontal gaze paralysis, which is very important. So, horizontal gaze paralysis can occur in metabolic encephalopathies. For example, hepatic encephalopathy, for example, uremic encephalopathy, or hyperosmolar states. Because metabolic dysfunction impairs the cortical control of gaze, brainstem reticular activating system, and also inhibits the inhibitory pathways. So this will lead to hepatic encephalopathy leading to impaired voluntary gaze, impaired saccades, slow down ocular movements, and they can also have gaze paralysis. So ophthalmoplegia, although classically associated with Wernicke's, ophthalmoplegia classically associated with Wernicke's syndrome, but this gaze paralysis these horizontal issues of the gaze, they are usually hinting towards hepatic encephalopathy. Okay, so this is a very good question. Now coming to third question in this series is EEG in coma. A 75-year-old woman presents with coma of unknown etiology. She has no focal neurological signs. CT brain is unremarkable. EEG shows periodic generalized spike and wave discharges. She is given 2 milligrams of lorazepam IV and becomes briefly responsive. So, what is the most likely diagnosis? Number one, brain death. Number two, structural brainstem stroke. Number three, non-convulsive status epilepticus. Number four, hypoxic ischemic encephalopathy. Number five, psychogenic unresponsiveness. Now we know that the answer is non-convulsive status epilepticus. But you tell me, how many people have you given injection midazolam in a already drowsy patient and you helped the patient become conscious? Now the answer is very clear, but why it is the answer, I need to know. If you want, you can go to the question again. That the patient presented with coma. So you in coma you gave IV lorazepam based on the non-convulsive status epilepticus. Isn't it amazing?
Because it is long-acting midazolam.
Yeah, that is fine. But I'm just asking you, have you ever given lorazepam or midazolam in an already comatose patient? No, never, no. It only happens when you have a EEG in hand. That you know the cause of coma is brain is occupied somewhere else. The brain is throwing seizures which are not coming out. So the only way to wake this patient up is either you give them electric shock of brain or you can give them benzodiazepines, but only after the diagnosis has been made, because coma can be because of anything, but here the coma is because of non-convulsive status epilepticus. This EEG, the pattern that was given, generalized spike and wave with periodic discharges, is classical for NCSC, that is non-convulsive status epilepticus. This EEG is never seen in psychogenic coma or brain death or even in any metabolic encephalopathy. This, if you ever see periodic spike and wave pattern in a comatose patient, ever, always confirm NCSC is there until proven otherwise. So immediately give benzodiazepines and the patient will have dramatic improvement after the lorazepam. Just a second, I need to take this call. Hello. सर वधिया वधिया तुसीं सुनाओ जी मैं लेक्चर लै रहा सी कोई गल नहीं हाँ जी दसो सर बड़ी देर पहला सीगा बहुत देर पहला मदर ते सन हाँ जी ਮੈਨੂੰ ਤਾਂ ਯਾਦ ਨਹੀਂ ਹੈਗਾ ਬਟ ਕੁਝ ਸੀਗਾ ਹੀ ਕੁਝ ਪੁਲਿਸ ਪਲਾਸ ਦਾ ਚੱਕਰ ਸੀਗਾ ਬਾਅਦ ਚ ਬਣ ਗਿਆ ਉਹ ਅੱਛਾ 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 ਸਾਡੇ ਕੋਲ ਤਾਂ ਜਦੋਂ ਆਇਆ ਸੀ ਨਾ ਦੋਨੋਂ ਜਣੇ ਘਰ ਦੇ ਇੱਕੋ ਪਰਿਵਾਰ ਦੇ ਦੋ ਮੈਂਬਰ ਉਹ ਅਸੀਂ ਤਾਂ ਉਹਦੇ ਪੈਰੀਕਾਰਡੀਅਲ ਐਫਿਊਜ਼ਨ ਨਿਊਰੋਮਸਕੂਲਰ ਵੀਕਨੈਸ ਸਾਰਾ ਕੁਝ ਸੀਗਾ ਸਾਨੂੰ ਔਰ ਪੇਸ਼ੈਂਟ ਸਿੱਕ ਹੀ ਹੋਈ ਜਾ ਰਿਹਾ ਸੀ ਉਹਦਾ ਕਾਰਨ ਵੀ ਕੁਝ ਨਹੀਂ ਸੀ ਮਿਲਦਾ ਹੈਗਾ ਸੋ ਮੈਂ ਐਵੇਂ ਇੱਕ ਦਿਨ ਸੋਚਿਆ ਮੈਂ ਕਹਿੰਦਾ ਨਾ ਆਰਸੈਨਿਕ ਲੈਵਲ ਕਰਾਉਂਦੇ ਹਾਂ ਕਿਉਂਕਿ ਸਿਮਿਲਰ ਜੀ ਪਿਕਚਰ ਦੋਨੋਂ ਮਦਰ ਤੇ ਸਨ ਪ੍ਰੋਗਰੈਸਿਵ ਡਿਜ਼ੀਜ਼ ਤੇ ਉਹ ਲੜਕੇ ਦੀ ਮੇਰੇ ਖਿਆਲ ਡੈਥ ਹੋ ਗਈ ਸੀ ਮਦਰ ਨੂੰ ਹੀ ਪੀਜੀਆਈ ਭੇਜਤਾ ਸੀ ਨਹੀਂ ਦੋਨੋਂ ਹੀ ਪੀਜੀਆਈ ਗਏ ਸੀ ਪੀਜੀਆਈ ਜਾ ਕੇ ਮੇਰੇ ਖਿਆਲ ਇੱਕ ਦਿਨ ਰਹਿ ਕੇ ਲੜਕੇ ਦੀ ਡੈਥ ਹੋ ਗਈ ਸੀ ਪੀਜੀਆਈ ਵਾਲਿਆਂ ਨੇ ਫਿਰ ਆਰਸੈਨਿਕ ਲੈਵਲ ਕਨਫਰਮ ਕੀਤੇ ਸੀਗੇ ਪੀਜੀਆਈ ਜੀ ਸਾਰਾ ਵਰਕਅਪ ਹੋਇਆ ਉਹਦਾ ਅਸੀਂ ਵੀ ਕਰਾਏ ਸੀ ਕਿ ਸਾਡੇ ਆਏ ਸੀ ਜ਼ਿਆਦਾ, ਤਾਂ ਹੀ ਅਸੀਂ ਉਹਨਾਂ ਨੂੰ ਦੱਸਿਆ ਸੀ ਕਿ ਸਾਡੇ ਕੋਲ ਜ਼ਿਆਦਾ ਆਏ ਨੇ, ਤੇ ਫਿਰ ਉਹਨਾਂ ਨੇ ਆਟੋਪਸੀ 'ਚ ਵੀ ਚੈੱਕ ਕੀਤਾ ਸੀ ਤੇ ਜ਼ਿਆਦਾ ਹੀ ਸੀਗੇ। No idea, sir. No idea. No idea. No, no, no. We don't have any idea. ਆਮ ਤੌਰ ਤੇ ਤਾਂ ਪਾਣੀ ਦਾ ਸੋਰਸ ਹੀ ਹੁੰਦਾ ਲੈਡ ਲੂਡ ਪਾਈਪਸ ਦੇ ਵਿੱਚੋਂ, ਬਟ ਵੀ ਡੋਂਟ ਹੈਵ ਐਨੀ ਆਈਡੀਆ। ਮੈਨੂੰ ਉਦੋਂ ਮਤਲਬ ਮੈਨੂੰ ਇੱਥੇ ਵੀ ਲੋਕਲ ਪੁਲਿਸ ਵਾਲਿਆਂ ਨੇ ਪੁੱਛਿਆ ਸੀਗਾ, ਲਾਇਰਸ ਨੇ ਬੜਾ ਪੁੱਛਿਆ ਸੀ। ਮੈਂ ਕਿਹਾ ਯਾਰ ਹੁਣ ਮੈਂ ਦੱਸ ਨਹੀਂ ਸਕਦਾ ਕਿ ਕਿੱਦਾਂ ਹੋ ਸਕਦਾ, ਆਈ ਡੋਂਟ ਹੈਵ ਐਨੀ ਆਈਡੀਆ, ਕਿਉਂਕਿ ਇਹ ਤੇ SRL ਤੇ ਹਾਂ 7-8 ਦਿਨ ਬਾਅਦ ਰਿਪੋਰਟ ਆਉਂਦੀ ਹੈ ਨਾ, ਉਹ ਸੈਂਪਲ ਇੱਥੋਂ ਲੈ ਜਾਂਦੇ ਆ ਤੇ ਉਹ ਤੋਂ ਦੂਰੋਂ ਆਉਂਦਾ ਆਪਣਾ ਬੰਗਲੌਰ ਜਾਂ ਬੰਬੇ 'ਚ। ਸਾਡੇ ਕੋਲ ਲੋਕਲੀ ਨਹੀਂ ਹੁੰਦਾ ਨਾ, ਸੈਂਪਲ ਲੈ ਕੇ ਚੱਲ ਜਾਂਦੇ ਫਿਰ। ਹਾਂਜੀ 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 ਓਕੇ। ਬਾਕੀ ਸਾਰੇ ਡਾਕੂਮੈਂਟਸ ਉਹਨਾਂ ਦੇ ਕੋਲ ਹੈਗੇ। Yeah, sorry. So this is very important. This is extremely important. The dramatic temporary improvement that you get after the benzodiazepines, it is actually called as wake up dose in NCSC. So if the patient is unconscious because of non-convulsive status, giving the dose can wake you up. You don't usually do that you give benzodiazepines in any other condition to wake the patient up, but this is one condition where only NCSC, where the cortex is actively throwing seizures and responding in this. All right. So next question is basically based on neuroimaging in coma. So a 55-year-old hypertensive male is admitted with sudden onset coma. Blood pressure is 190 by 110 millimeters of mercury. Exam shows right gaze deviation, left hemiplegia, pinpoint pupils. GCS is 5. CT scan shows a large pontine hemorrhage. Which of the following clinical feature is most characteristic of a brainstem structural coma? Number 1, preserved pupillary responses. Number 2, early hemiparesis without cranial nerve findings. Reactive EEG pattern. Number D, pinpoint but reactive pupils. Number E, Chine-Stokes respiration.
Chine-Stokes respiration, E.
So pinpoint pupils but reactive in nature. Why? So what we have here is examination. We have a pontine hemorrhage. So in pontine hemorrhage, there will be pinpoint pupils. Okay. So this is very important. The sympathetic pathways, they run through the pons and the pons is destroyed. So there is unopposed parasympathetic, that is Edinger-Westphal nucleus, uski tone. So when it is increased, there is pinpoint pupils, but the pupils always remain responsive because the parasympathetic nuclei controlling the constriction, they are usually intact. This combination of small pinpoint but still reactive is classical hallmark of brainstem structural lesion. So in examinations, the most classical triad that usually is asked is number 1, pinpoint pupils, number 2, coma, number 3, quadriplegia. So this situation matches the situation. So why the other choices like reactive EEG pattern? EEG in structural coma tends to be focal slowing because that area of the brain is not working, or severely abnormal, sometimes suppressed. A reactive EEG pattern, that like mentioned C choice, is more typical of metabolic coma, not structural lesions. As far as the answer that you gave, Chine-Stokes respiration, now Chine-Stokes is basically diencephalic or bilateral hemispheric dysfunction. So whenever brainstem is under the effect of the swollen brain upwards, only then it leads to Chine-Stokes respiration, or it can happen in patients with metabolic encephalopathy, not a hallmark of pontine lesions. So pontine lesions usually produce central neurogenic hyperventilation or agonal breathing patterns or failure to sustain breathing. So here the final answer would be pinpoint but reactive pupils. Okay. So we need to read this, that pupils may still be reactive if the Edinger-Westphal nucleus is paired. Okay. Prognostication after cardiac arrest. So prognostication after cardiac arrest is very important. Here is a question for that. A 60-year-old man is comatose after out of hospital cardiac arrest. He underwent a targeted temperature management TTM at 33 degrees Celsius for 24 hours. On day 3 post-arrest, he has absent pupillary and corneal reflexes, status myoclonus, and bilaterally absent N20 potentials on somatosensory evoked potential, that is SSEP. Which of the following best describes his neurological prognosis? High chance of full neurological recovery, likely to remain in minimally conscious state, poor prognosis, further testing required, highly specific predictors of poor outcome, or cannot assess the prognosis until day 7. So the correct answer is that these neurological tests that have been done, they are highly specific predictors of poor outcome. Okay, now basically the poor prognosticating indicators are after TTM, after ROSC, they are absent brainstem reflexes, status myoclonus, and absent N20 SSEP bilaterally. Now they have a very high specificity for poor neurological outcome. Why these predictors are so specific? After 72 hours after ROSC and after rewarming, we need to know the bilateral N20 responses on SSEP. Now this SSEP, this test, this is single most important test, this test, single most important predictor of poor neurological outcome. False positive rate is as low as 1%. Absence means severe cortical injury. So there is no chance of any meaningful recovery. So having N20 SSEP done and showing nothing bilaterally, it is the most important poor prognostic indicator. Rest of the things like absent pupillary reflex and corneal reflex on day more than 3, this is also very important with specificity standing more than 95%. Status myoclonus within 24 to 72 hours. Early generalized persistent myoclonus is a strong indicator and predictor of hypoxic ischemic injury. So whenever we are talking of कि patient hypoxic injury है, so we are always saying उनको myoclonus आ रहा है. Why we are saying that? Because myoclonus itself is a very poor indicator. When all 3 are present, that patient has myoclonus. See, the patient has myoclonus, the patient has absent pupillary corneal reflex and bilaterally absent N20 potentials. We are already sure that the patient has a near 100% chances of poor outcome, and neurological recovery is essentially impossible in such a patient. So these questions are now taking precedence in ESICM and the EDIC examinations. So you have to read about prognostication after cardiac arrest, when to assess at least 72 hours after ROSC and after the rewarming from TTM. Predictors, as I've already told you, absent pupillary reflexes, absent corneal reflexes, no motor response to pain, absent N20 responses on SSEP, unreactive or burst suppression EEG, status myoclonus, onset within 24 hours. TTM is important now, maintaining temperature at 32 to 36 degrees for 24 to 48 hours. It reduces secondary brain injury. It can delay the recovery, hence prognostication should wait until rewarming. So always do the SSP after proper rewarming. Neuron specific enolase nowadays is a research molecule, can be tested if available, then more than 33 microgram per liter will suggest poor outcome. So that is all for today's class. Thank you for your patient listening, and I hope this class will help you do more questions based on these data. Thank you very much and have a good weekend. All right, bye bye.